All right, everyone. Hello and welcome. We'll give everyone just a moment to start joining us today. Let's see everyone coming in. We'll give everyone just a couple more seconds. All right, I'm going to go ahead and kick us off. So welcome, everyone. Today, you're going to be hearing from the Vatica Health team on innovative paths to success in today's MA market. Today, your presenters are going to be Matt Neese and Eric Wallace. Before I turn it over to them, I am going to go over just a few housekeeping items. So we can go over to the next slide. So you will notice for the duration of the webinar that your camera and mics are going to be muted and off for your privacy. But please, if you do have any questions, enter those into the Q&A box at the bottom of your screen. If there are any questions that the team's not able to get to during the duration of the webinar or at the end for the Q&A section, they will follow up with you directly afterwards. But without further ado, I'm going to go ahead and turn it over to Eric to kick us off.
Great. Thanks, Bailey. And good afternoon, everybody. Thanks so much for taking some time out of your busy days to spend with us. Matt and I are excited to talk a little bit about topics that are, really near and dear to us as we spend time in the market with both Medicare Advantage plans as well as providers who are working in contracts with many of the health plans to really dive into how we're seeing innovation work in the market. So just in terms of what we want to cover, and then I'll do some quick introductions here and then turn it over to Matt. We want to just highlight some of the opportunities that we see in light of many challenges happening in the market in the MA space, and then cover within those challenges where we see, real opportunity that's been produced through bringing the payers and providers together in innovative collaborations. And then really just understanding what is the key to driving success in these collaborations, bringing the parties together with some key takeaways that we hope will be useful in your day-to-day. So I'm Eric Wallace. I'm Senior Vice President for Provider Sales. So I lead all of our provider-facing activities for Vatica Health that encompass work with health systems all the way down to individual provider groups. And my background is I've been in healthcare for roughly about 30 years, most of which has been on the provider side. I spent some time in health plans, one of which was a customer of Vatica's when I was working at the plan. And so much of the work that I've done over that time has been really around provider collaboration and health plan collaboration and the move towards value-based care. So Matt, I'm going to turn it over to you.
Yeah, good afternoon, good morning, everyone. For those on the West Coast, my name is Matt Neese. I am Vice President of Vatica. I work across our payers and some of our risk-bearing provider groups to identify how they can improve their risk adjustment. I've been in the industry for over 15 years, about half that time on the payer side and the remaining time really providing services for those payers. So as Eric mentioned, we're both fortunate that we get to see how a number of different organizations approach the current market challenges. And we're really excited to discuss some of those ideas with you today and share some of the learnings that we've seen across those different groups. So look, this may be obvious to many of the people on the call, but to set up the discussion today, we wanted to level set on some of the major changes and pressures in the MA market. Some of these items that you see here on the left-hand side have been ramping up in recent years, but really at the end of 2024, we saw an inflection point where the pressures from those items drove very specific actions on behalf of the payers and certain demands. So for example, on the left-hand side, you see a number of items that create significant financial pressure. And the result of that came out of that has caused a number of payers to move from what we describe as a very strong growth position, growth at all costs within the MA space, to being much more selective, being much more strategic and careful about how they participate in individual markets. So we saw some payers exiting markets, being selective with which counties they work with, being selective about their network and changing their network philosophies as well. And if you've been in the industry, I don't think any of these are new. It's just about an increased level of activity that these are driving. And what the last point I'd make on this, while we've got this picture up here, and we'll go through each of these items, but really today's conversation is about risk adjustment. But And its risk adjustment is key based on the revenue impact and the importance it has to the business overall. But what you can see is that most of these items that you see here, both within the current environment and within the payer response, have some overlap with what we're going to talk about here today in risk adjustment.
Thanks, Matt. Yeah, so I think what you laid out is, pretty sobering, but an accurate picture on pressure in the MA plan market. And one of the points you had, which I would just underscore, is this move to shifting risk from the health plan side to the provider side, which is very much a shared point of pressure health plans have with providers. So let's just talk about that. And how does innovation play a role in addressing the pressure on health plans and providers to better manage total cost of care risk? So the outcomes on the screen that we're showing really represent what art of the possible is. And what we regularly talk to our health plan clients about is, how do we build successful collaboratives with providers on risk sharing? Understanding that, providers are transitioning from mainly a volume-based reimbursement system or fee for service to value-based payments. And value-based payments work in such a way that when they're well implemented, both provider and health plan are rewarded for delivering high quality care at affordable, competitive prices. So this new model for care is transformational, and it does require payers and providers to do business with each other differently. It also requires intentional innovation with clinically oriented platforms to enable successful collaboration. So as Matt said, what we do at Vatica Health is, we enable health plans and providers to collaborate successfully, and mainly in continuous quality improvement, where we focus on primary care physicians. So the solution that we focus on and the outcomes you see is really about how do we help physicians make this transition successfully. So we're highly focused on supporting their transition, but in being able to accurately and compliantly document and code clinically appropriate health conditions, in addition to highlighting quality of care gaps at the time of patient encounters. So in the graphic here, what we show you is how when clinical teams do work collaboratively in platform, and we're really able to transform how primary care visits are conducted, we can produce value for both the providers and health plans. And with aligned incentives with the work being done, it is possible to drive better financial and clinical outcomes that ultimately benefit the patients in their care. So from a payer's perspective, you see on the left-hand side, what they're mainly interested in is making sure that we are able to accurately code the acuity of the patient. So you'll see in this particular instance, we worked with a large $1.4 billion health system in the Northeast. We were able to capture over 13,000 hierarchical condition codes, HCCs, hierarchical condition codes, HCCs. And we were able to achieve 85%, within 85% of all visits, at least one capture of an HCC. And then 70% when we're able to engage successfully of these PCPs, we're actively in the system. So again, this requires behind the scenes to make this all work, an incredible amount of trust building, of understanding how to build into the workflow of having the health plan sponsorship and support, and ultimately translating into the work that that the providers are doing to be successful. And from a provider perspective, we want to ensure that providers are able to achieve revenue and compensation for the time that has been part of this transformation. So you'll see on the right-hand side, roughly in this case, about 1.6 million in annual incentives were provided to the provider system through effective collaboration. So by bridging the gap, we're able to demonstrate both parties can be successful. And Matt, I'm going to turn it to you to talk a little bit about how we've done that.
Yeah, thanks, Eric. So this is a little bit of a picture. Eric and I are fortunate we have the opportunity to work at a place that services both it really is a safe bridge between the payer and the provider groups. Vatica started as working with PCPs to assist with annual wellness visits, and leadership really recognized that this prospective preparation for encounters could greatly assist in risk adjustment activities. And it's out of that we grew. Our focus is providing value by leveraging both technology and clinical staff. What we found is that technology alone is not sufficient to drive true provider engagement and more accurate risk adjustment. So with the Vatica approach, we leverage registered nurses to use our technology to curate both payer and provider EMR data to provide the most complete and accurate prep for a member encounter with a provider. This has, and the key here that we referenced in that previous slide is this has value to both the payer side for their risk adjustment, but it also has value to the provider side in terms of easing their preparation, helping them with the things that they need to do that they're struggling with. So we work with national plans, regionals, blues, and we work with a very wide variety of payers, both very large provider groups and smaller provider groups across the board. The key here that we're going to keep going back to is that the key to the success is that, and every payer needs to find, is the key to enabling that collaboration between the payer and the provider is to do it in a way that is safe and greatly benefits both sides, specifically the provider side, to keep that engagement. And you can see here a couple of the items that globally that we've had as risks as we've continued to grow across the US and how we operate. So some of those key themes are the ideas that we're going to be talking about here today.
Great. Thanks, Matt. And I think, you know, as you said, where we sit between provider and health plan, I think what makes, you know, this opportunity around innovation so exciting is really about how do we remove from that position the barriers to collaboration. And when the incentives are aligned to achieve the shared set of objectives, it really unlocks opportunity for continuous improvement and ultimately affordability for the patient. So, for example, you know, we've invested tremendously to understand physician behavior, to continuously improve how physicians engage so that it's efficient and effective. A lot of organizations talk about physician engagement, but when we're doing this at scale, we can really understand how to drive value in these value-based arrangements that are of interest to both parties. And look, this work is challenging for a single health plan to impact on their own, even for CMS, which is the largest payer, because physician practices have patient panels that are multiple payers and multiple lines of business. So trying to balance each of those competing interests and try to do the work effectively really can be a challenging for provider organizations, which really underscores this point of having a collaborative mindset and being innovative in how you'd approach this. So the way, really the way we go about building physician trust and engagement is just to simplify and make it clinically appropriate in ways that remove those variations and as much as possible, simplify the different payer requirements so that the providers can focus on patient care. And then when the incentives are aligned in that system, physicians then begin to build trust that what you're asking them to change, it affords them an opportunity to reinvest and expand into the broader quality improvement and affordability initiatives that we're seeking under value-based care. So as we referenced earlier in the case study that I showed, we're showing roughly about an 1,800 average incremental improvement in the risk-adjusted premium from the work providers are doing, which is a critical resource. You think about the investments, and that's a per patient basis, and then the investment that's required for transformation to cover, healthcare services for the patients with highest acuity as well as other, ongoing day-to-day physician practice activities. So physicians really need to be able to do this in such a way that they trust the data that's being presented to them, that's clinically appropriate, it's transparent in how it's sourced to them. When the PCP's time is necessary and isn't directly related to patient care, they also need to be fairly compensated for these efforts with appropriate support from experts who are in compliance, which, line that we often hear from physicians is, I went to school, but I didn't learn how to be a coder. So we need to give them appropriate support, right? End to end, not on a per payer basis, but on a broad basis. And when we do that, when we have a team fulfilling their roles from end to end, we start to see the results, that really underscore the value of collaboration. So this is why innovation is essential. And without it, we'll continue to see physician burnout and continued dissatisfaction in payer relationships. So Matt will cover the next two.
Yeah, and when we talk about the physician's perspective, this is key as you're in the payer space to take that physician perspective. So everything that we've led up to, whether it's collaboration, whether it's trust, whether it's quality, whether it's compliance, whether it's focused on the members' care, right? One of the keys that you're gonna have is this efficiency, and this is an overarching goal. And when we talk about that, it's the payers are taking from the payer perspective, moving away from this growth at sort of all costs and looking at how to effectively handle some of these cost pressures within the market. And there's a number of different ways that groups are doing it, whether it's market position about how the payer is doing it. In some cases, it's internal operations, but it's most definitely involved with this payer collaboration. So as I think about what we've seen, and we look at as we work across a variety of very different payer groups, and we look at the internal workings of those payers, we've seen, first of all, most of the payers are expanding the groups that have accountability for risk adjustment. This is a good thing. So what the recognition here is that risk adjustment isn't just a standalone measure, right? But it's really an outcome of several different things that come together to do this across the payer organization. That's a good thing, because getting groups aligned on the payer side is key. Any challenges that you have on the payer side, in internal groups that you have, or misalignments that you have before you go to the provider, will reduce provider engagement. So it's very difficult for the payers to walk in the shoes of the provider. But it's absolutely critical that you're realistic around how the providers feel about the payer side, and make sure that you do everything you can to enable the provider side and meet them on their terms, whether it's optionality about how you go to market, whether it's communications within your team, whether it's your network management teams. All of those things come together, because the reality of this is that the benefits that go to the plan really require the plan to give the right information to the provider, removing those barriers. And this should be part of a continuous improvement, a constant cycle as we change every year. But regardless of how it does it, we want you to think about how this touches many different departments within the plan. And we need to look at that quality that comes out of that as one of the key objectives. And you need to have that communication across different groups within your areas to make sure that you're meeting those quality objectives. One of the questions, so all of this is a good setup, but as we go into there, how to make this real in your environment, right? And if we think back to the case study there presented earlier, and we think about some of the themes that we needed to get done in order to see those results, first take a look at the graphic on the right-hand side of the slide. This is not meant to be in a complete inclusive list, but you should consider at least these items to address these items holistically within your risk adjustment program or your risk adjustment strategy. If you don't, and you leave one of these items out of the picture, out of your planning, out of what you're doing on your side, you're certainly going to struggle with risk adjustment. Either you won't see the results you want to have, you won't get the provider engagement, you won't have alignment across your internal organizations. So obviously we're taking a risk adjustment perspective on this, but you can quickly see how does this play in with our stars and quality? How do analytics feed in what we're doing? How are we using intelligence about what's going on? And one of the things that you need to avoid at all costs is putting noise and confusion in front of the providers, right? Providers are well overwhelmed by the information that's pushed at them. That signal fatigue that comes at the providers day in, day out. We need to be very judicious around any information that goes to the provider, any ask that goes out to that provider. We need to be hypersensitive to their time and their energy, because if they don't trust it, if it's not clinically sourced, if it doesn't make sense to them, if it's not actionable, it certainly will, they'll just ignore it, and it will just be another thing that's on the provider's plate that they just have to tune out in order to engage with their patient that they're interested in, right? And so when we see these things, these other aspects of really what's going on in the groups that you need to work with in the payer side, right? Your provider network management team, this an effective risk adjustment program cannot be done, and the impact to the provider group cannot be done unless you're really there with the provider network team, and you're really honest and candid around the reality that you have in your relationships with different provider groups, right? You have to understand that one size does not fit all when it comes to individual provider groups and how you reach out to them. You should use intelligence about that. You should gather more intelligence and use your analytics that you have against your provider groups and think about what this means. What does the provider have in terms of their contract type? What do they have in terms of the risks that they bear, their historical performance? What are their issues? Are they rural or urban? What is their panel made of? What are the challenges that they have? How well do you know them? Understand that there might not be a strong level of trust between that provider and your organization or the payer, and take that into an absolute reality. We're fortunate in that we serve as a neutral third party that's able to bridge that gap. So that's a natural advantage that we have. But that's one of those things that must be considered within every risk adjustment program, right? You can imagine that the information that goes both into risk management comes out of that is absolutely key to your medical management programs, right? And doing this in a timely manner and having those things connected, right? It does not do you any good to have information that is incomplete, information that is not integrated into the broader system, and just throw random pieces of information at a provider that will not work, right? All of this is leading up to like, hey, what does this mean to the plan in terms of the revenue? What does this mean in terms of how they can go to market? What does this mean in terms of how they can design their Medicare Advantage programs, right? All of these things play into a broader perspective that equals success within the Medicare Advantage market. Now, the good news around this is that this doesn't require a major transformation or major reorganization at a payer, right? This can be done. This doesn't require a big Herculean effort. For payers that we work with, it's really about bringing these teams together quickly to focus what are the key areas of risk adjustment that they want to focus on? What are the provider groups? How do they look at these groups? How do they prioritize the work? What are they doing in terms of segmenting their providers and their member populations and pulling these groups together to get a unified, like I said, continuous improvement plan with all the right people in the room, all the right people signed off. Eric, I don't know if there's anything else you wanted to weigh in or add on to that.
No, I think it's well said, and I think the idea that the collaboration happens between the payer and provider, as you said, just to underscore it, there's a requirement for collaboration within the four walls of the payer is very true, just given there's a lot of dependencies when we talk about collaboration and the different interests that are within the payer organization. And quite frankly, then how do we connect all that to the point of care with the patient? There's a lot of moving pieces there. There's a lot of team members that have to be coordinated. And so I think, the easier you make it, more you can provide support to that provider organization, as you said, that really does fuel the collaboration to work successfully. So I just want to, Matt, I know we're running up against time and we've got one more slide to cover here. Just encourage folks, if you've got questions, to pop them into the Q&A, and we'll leave some time at the end to cover those.
Yeah, so the first, as we take a look, going back to kind of the big picture, the first thing that I like everyone to think about is really that, hey, in the market today, as we talk about how this is changing, everybody knows that there's a push to value-based contracting with provider groups. And as we think about that push, about how provider groups can share in that risk and really be accountable for the health of the patient, how do we enable that, right? We can't continue the way things used to run in terms of contracting. So how do we enable that? How do we really make sure that both the payer and the provider win within that value-based contracting arrangement, right? And this accurate coding that we're talking about within risk factors and pulling this information together is, I believe, table stakes for really making that movement to value-based contracting. So if I was doing more senior level consulting with a group and they said, hey, how do we with a payer, how do we move more of our providers to get further on the risk-bearing spectrum? I would really, one of the items I'd be is like, take a look internally is how we're setting them up for success within this risk-bearing, within this risk adjustment, and how this impacts their value-based contracts.
Yeah, and I would agree that, when you take the provider side to that, which is, in order to be successful in this new way of delivering care under value-based arrangements or contracts, there is absolutely new work that we're being asked as providers to do. And that requires new resources. So connecting and being able to explain that this is not administrative work for the sake of administrative work, but really being able to, demonstrate that through improved accuracy in a compliant way of coding or of representing the acuity of the patients, that ultimately this advantages the provider in that what it will provide additional resources, but also just additional understanding of the patients that we have under our management. And, this again is not the domain that's exclusive to the health plan, but it's a collective responsibility to understand. And if we don't do those basics really well and enter into an arrangement that says we're going to talk about managing risk or we're going to shift risk and not do the basics, it's really hard to do the more complex things that we want to do around making sure that those patients are getting connected to the right specialists, they're getting appropriate benefits assigned to support them outside of practice of physicians. So in their home and in the community, all of this gets to true population health models, is understanding what the underlying risk factors are, so I know what to manage.
Yeah, and when I think about the payer effort to enable effective programs, there's a couple of landmines that we really need to be careful of, and this is certainly true in my past life before I, worked at Vatica, is that we worked at big payers, and there was a specific challenge in that when the plan came to determine how to do these things, they would often say, "Hey, we're the biggest payer in these markets. We're gonna build a portal, or we're gonna do it this custom way for our plan, and since we're so big, we can push the providers to use this." And that was really unsuccessful in every way. That really was that those approaches really don't work. And today, even today, when I work with a number of our different payers, I'll often talk to them about, hey, what things have you tried in the past? None of this is, risk adjustment isn't new. It's been on the market for a while. So, we're fortunate that we get to learn from these. And a lot of them did have homegrown solutions that they tried to push out there that were really viewed by the provider group as being a payer-centric approach, or was, hey, this is insurance. That when we talk to the provider groups, they would say, hey, this is insurance work that I need to do. And so there's nothing more dangerous or destructive to a risk adjustment program and this collaboration that we're talking about than having a provider view a specific approach as being insurance work or paperwork, right? And so when we talk about building that trust, when we talk about building that collaboration, it really helps. We're fortunate that we're a neutral third party, so we come to the table as that neutral third party, that we can represent both sides fairly and equally, and we can do that transition so that when we're working with the provider, we are doing the right things on behalf of the provider, and then we're working with the payer, we can do the right things on behalf of the payer. That's one of those hurdles that you need to do. And I want you to really stop and think about that actively. One of the things that I've also seen as sort of an anti-pattern or a bad idea is that many groups with good intentions realize that provider collaboration is extremely hard. It's the hardest thing to do within risk adjustment. And what they end up doing is really focusing on everything but the provider collaboration. They feel it's very hard to change. And so they spend a lot of time and energy on, advanced AI or analytics, or they're working all around, but they're not really tackling that absolutely critical piece of that provider collaboration. And what we find is no matter how much time and energy they spend on the periphery, if they don't tackle that core problem, they will not get the results, no matter what type of work they do before or after. So having that trust, having that collaborative relationship is the absolute key thing.
Yeah, and I think as we talked about earlier, Matt, when we think about building this team between the payer and the provider, with aligned incentives and transparency is the other word that comes to mind, right? To help build trust is, there are multiple ways that we engage around data, which is, data the health plans have through claims. It's data the physicians are entering through encounter notes into the EMR. It's other data that we're integrating to try to pull a story together, and then being transparent around where that data comes from to build trust. I think probably one of the biggest challenges that physicians are facing. You talked about this earlier, which is alert fatigue. So it's more than just alerts that are coming at them, but coming at them where it's not necessarily clear the source of where that data is coming from. So it's a barrage of data, which is good. We want more data, but data absent transparency and absent the context of what I'm doing when I've got that patient in front of me or after the visit to do what's in the best interest clinically of the patient. Without transparency, it's really hard to build trust. And I'd sort of say the other part of building trust is then building a framework around which team members can collaborate, right? So I think the other buzzword we hear a lot about are, team-based care and everyone on the team practicing atop a license. And, there are multiple team members that are required to deliver really excellent patient care. In addition to, ensuring that as part of that team, we're covering compliance, we're covering revenue cycle, right? So we still have these responsibilities across these multi-stakeholder teams within the provider environment, just as there is multi-stakeholder collaboration requirement within the payer world to try to really simplify and make this work for the provider. So I would just sort of end in terms of the slide, and then we can cover a couple questions that have come up. Just in terms of how this translates the work that we just described specifically for practice, which is just to say, through the work that's been done that we describe, right? Which is if I can get the team working effectively, get trust in the data, when I've got the patient in front of me, close the, from the information I have, accurate condition coding, look at where there's potential to close gaps in care, and increase accuracy in this instance, 10% improvement in accuracy for coding for patients. What this translates to from again, boots on the ground practice perspective are, real resources that support, nurses around patients who have needs and transitions to care, supporting patients in ongoing chronic care management, resources, pharmacists, added to the team who can help around med reconciliation and support for those patients who are polypharmacy users. And so while everything we just described, feels like it's outside the domain of, what is important to the patient and what's important to the clinician delivering care to the patient, they're fundamental to delivering, ultimately better care, connecting those resources to the patient. So Matt, before I go over to the questions, and I'm just noticing we've got a couple, give people time to enter in a couple more. Anything else you would want to add, and then I can toggle us over to questions.
No, I think that's well said. I think that's well said. And we can go into questions again. We can jump into the questions. I'll read them off. Please put them into the Q&A section. You should have it at the bottom of your screen. You can enter in questions. Happy to that would help. And maybe I'll queue up the first one. I love
Sure.
this question. Thank you, Robin. This is close, near and dear to my heart.
Hmm.
I'm wondering how effective you can be if the organization does not have a broad integrated data set to begin with. Right. So Eric, before I jump in, I'll turn it over. I'll ask if you have any thoughts before I jump in on that one.
Yeah, I mean, I think this is one of the largest challenges that, we're seeing, which is how do we achieve the outcomes we just talked about absent data? Um, and I would even somewhat jokingly refer to a few conversations I've had with folks on the provider side who, have been in negotiations with health plans and value-based contracts, and the simple answer they have is, no data, no deal, right? So if I cannot pull data into the process that I'm building in order to manage the uh, outcomes within the population I'm responsible for, it's really hard to drive the outcomes we just talked about. Near impossible. You're sort of putting a finger in the wind and hoping for good results. So I think, Matt, what we're responding to here is yes and yes and yes. You have to have the ability to integrate data. So that is table stakes for us, to the extent that, when we form a partnership with a health plan, work with them to go to market, to then engage providers in this collaborative space. It starts with making sure we have accuracy and transparency of the health plan data set to bring to the providers. And in some instances, providers are already working with payer data. That's great. In other instances, they're struggling with it, and that's a problem absolutely that we want to solve for them, help them solve, so that they can focus on patient care.
Yeah, and Eric, I would kind of add into that. Look, I worked with one of the largest national payers and know intimately their certainly their member data, but also connected with their provider data that I work with. This is going back to my start in healthcare. And I can tell you, when I looked at the reality of that payer data, it was spread across a number of different legacy systems, right? It was spread across different lines of business. If you had a question that said, "Hey, who is Eric Wallace?" we would say, "Well, what database do you want to look at?" And we might give you a different answer, right? And so I know the business reality of large payer systems, legacy systems, and the confusion that comes in with that. And what I would say is that in a perfect world, we need that integrated data. The more that we have that data integrated, the better off we're going to be. And but I don't let that stop you, because I think that your net perfect is never going to happen, either on the member data side or on the provider data side. And so what I would advocate for is kind of a couple of different approaches. Number one is that on the provider side, what you'll find is that provider data is notoriously difficult to keep updated and keep clean, and even if it's just down to the addresses. But when you're looking at your risk adjustment strategy and you're working with your network team and you're trying to break out, how do we go out there? Plan on some time with, like, literally looking through, talking through, working through, even if it's a spreadsheet exercise. What is this provider group? What do we know about them? What don't we know about them? How do we gather more information? There will be some effort there. The second thing on the member side that we actually had to do, and this is less than perfect, but it was a national insurer, we did have to do what we kind of lovingly called some sneakerware, which was, as we looked across different data sources, how do we pull in specific members and start with even a subset of the Medicare Advantage members, or the markets where we have where we can get the best view of the member, the most information on the member. So again, it doesn't have to work for every single member across your MA organization. It doesn't have to work for every single provider across your organization. But what things can you do, even if it's a little bit of duct tape? What things can you do to pull that information together so that you can take action on it, even if it's incomplete, even if it's less than your complete population? I would advocate for you trying to do that. Allocate some time with that. Build some partnerships within your analytics, within the teams that manage your data, and ultimately within the network management teams. Building those relationships and advocating some time for that and pulling them into that solution and that payer side collaboration is really going to put you in the best spot for working with the providers, because again, we want to insulate providers from any sort of noise, confusion, incorrect data that you've got on the payer side. That's going to be key to in maintaining their engagement.
Yeah, and Matt, I would just add, because again, I think this is a great question, which is back to data. the position the health plans are looking for in this collaborative space, which is a challenge, is, clearly the payer data set and all the challenges you just described are key to success. And from the health plan side, the other key to that is marrying the data with what the patient encounter notes are within the provider record and bringing that together into a comprehensive view. And so just as you said, within the payer world, we can't let perfection be the enemy of good. So we've got to be able to wrestle the data and put it into a context for the physician practice. We also need to be cognizant that within the provider record, pulling the data together, whether it's in a paper form, whether it's in an EMR form, we see all kinds of different environments when we go to the market with our provider clients. But, irrespective of how they're currently recording all that information in a patient chart, what the health plans really are seeking is the ability to pull that all together into a single patient view for the physician without getting in between the physician and their EMR and their workflow, right? So I think, where the benefit of being that trusted third party, that intermediary, as you said, to deal with the health plan data, to create that integrated view, to really understand how to remove the barriers for the physicians to interact with the data in a transparent manner to move the needle. That is what good collaboration looks like. That is what creates and drives the outcomes. And I would just say, no one payer can do that on their own, right? So I think when we talk to the payers and they talk about wanting to do things differently and really drive the results around MA performance and partnering with their provider network, having a trusted third party, that kind of Switzerland in between that can pull that data together, is just really critical.
And the next question, and I think that ties in nicely to the next question, which is, can you integrate monthly performance claims and risk adjustment data supplied by each payer the organization is in a value-based relationship with? And the short answer to that, I think, is absolutely right. And sort of more globally, you're thinking about the way that you're thinking about that is absolutely correct. And what you want to do is as you look across these different things, whether it's claims, risk adjustment data, the monthly performance scorecard for the specific provider groups is really make sure that you've got on the back end of this the right way to pull those things together all the way, because you're, again, working in this heterogeneous environment across a number of different payers. It's all about getting that transparency. And so what we spend a lot of time doing is you're looking at everything soup to nuts in terms of, hey, what are we getting, what's coming back in the claims, what's coming back in the risk adjustment, what's in the MAO4s, what came out of those post-coding audits, what do you see within other programs? What are you seeing within your membership population across, your medical management, case management programs, CCM programs, et cetera? All of those things are very valuable as you move into that value-based relationship with specific provider groups. Again, it's helping enable them to take on that risk that they otherwise couldn't take. Eric, I don't know if you want to add on or have thoughts on that front.
No, I think that's really well said. And what I would say, just in terms of how we think about, again, this connection of data and doing things differently. What I often hear, and being guilty of this, myself, having spent some time working on the health plan side, is, we do a really good job as a health plan pushing data out, putting information or insights into provider offices, but then we kind of leave it at the doorway, but don't know what happens once it hits the doorway. And again, I think this is where, when you listed, Robin, integrating all this data, I think what you're getting at is there's this inundation of reports of, payer representatives coming and pointing to the data that I'm sending to you and asking how you're translating that into action. That's not good collaboration. That's not what we're talking about here. And particularly when it's not pulled together with the notes and how I'm communicating with the patient when the patient's in front of me, even pre-visit planning, right? And what do I have to integrate into my pre-visit plan? Like those are all the heavy lifts. That's all the hard work that's necessary to be able to really drive value in a value-based relationship. And should be, again, table stakes, right? Both parties should come to the table understanding that, this does require a lift. This requires both sides being engaged and at the table to make this work. It's not just throwing data over the wall, leaving it at the doorstep and hoping we're going to see change in outcomes. The work that we just described to get to the outcomes we showed, it takes a lot of work. It takes a lot of work building those roads, building that trust, gaining physician buy-in and gaining their confidence that what they're doing is going to be in the interest of their practice's financial strength. It's going to support their practice, but ultimately support their patients.
Fantastic. Before I turn it back over to Bailey for sharing the slides, the survey, some follow-up information, any other questions? If not, and again, as we're available if there's any other questions offline. Certainly, you can follow up. But Bailey, maybe I'll turn it over to you to cover any post-meeting logistics.
Yeah, thank you so much to Eric and Matt for putting on a great presentation today and the Vatica Health team. As Matt mentioned, there is going to be a webinar experience survey that has popped up on your screen. So if you could just take a moment to complete that for us and let us know how we did today. You will be receiving a email from Rise tomorrow following this webinar. This will include a link to today's recording as well as a link to the slide deck as well. And I see we're filling this out, which is great. We're going to give everyone just a couple more seconds.